Hello students, how are you all doing? In this chilling winter morning, let us discuss about renal function test. Now depending on what time of the year you're watching this video, it might not be winter at all. However, this topic remains important throughout the year, especially when exams are nearing. You should always know these function tests because this will be asked in both theory. It may come as a long question or as a short note, and most importantly, it will be asked in viva of both theory as well as practical exams. So what are renal function tests? Renal function tests are those bunch of tests that detect any damage to the kidneys. Alright, kidneys may be damaged in many reasons. Kidneys are the final filter that saves your body from getting rid of harmful substances. I'm sorry. Kidneys can be damaged in many ways. Kidneys can be damaged in many ways. Kidneys act as a final filter that helps your body from getting rid of useful substances and prevents your body from accumulating harmful substances, right? So in this process, there are many ingredients that can actually harm the kidney, and various disease process like diabetes, hypertension makes their major brunt on the kidneys only. Anyway, so renal function test number one, it can detect any damage to the kidney. If the kidney is already damaged, it can monitor how much damage is taking place. So it can monitor the functional damage of the kidney. And lastly, it may also help us determine how the kidneys are getting damaged, to help us determine the etiology of the problem, right? So these are the utilities of renal function tests. I already told you, renal function tests are a bunch of test parameters that detects the normal functioning of renal system or the kidneys. Okay. So what are the tests of renal function? The tests are GFR, right? Glomerular filtration rate, serum creatinine, most commonly used in all patients that are admitted or that are not admitted, that will turn up in your chamber. You will prescribe serum creatinine if you want to know about the kidney function of the patient. Serum urea, both urea and creatinine goes hand in hand. However, creatinine is more important compared to urea. Blood urea nitrogen, it is more closely related to urea, but we often prescribe BUN instead of serum urea because it also gives us a bigger picture. All right, these are the parameters that we are interested in. However, there are certain ingredients or there are certain changes in urine that may lead us to order, that may give us suspicion to order these renal function tests. Those are urine volume, an abnormality in urine volume, presence of protein in urine, urine may appear frothy, all right, presence of glucose in urine. The original diabetes was actually discovered when uh, the test subject discovered ants sticking to his urine sample. Okay, he did forgot to flush after peeing. Anyway, so glucose, urinary glucose glycosuria is a very important indicator to order a full panel of renal function test. Any blood in urine, all right. So hematuria, very important. Always there is a disease process. It cannot be normal. Glycosuria, proteinuria can be normally found. I will be discussing them in a separate video, but hematuria is almost always pathological. And lastly, change in urine osmolality. Alright, we can measure the specific gravity of urine. If there is any alteration, there must be some disorder in the kidneys. And lastly, of late there is a new emerging parameter, that is the value of cystatin C in plasma, that also gives us an idea about renal function test. So if you have got a good setup, apart from all these, you can also order cystatin C in plasma. It is not used much because it's costly, but if you have the setup, you can definitely order. Now there is a relation between serum urea and BUN that you must know. Approximately serum urea is twice that of blood urea nitrogen, specifically 2.14 times. So a BUN of 10 means 21.4 mg per dl urea. Both have the same unit, milligram per deciliter. So 10 mg per dl BUN is equivalent to approximately 21.4 mg per dl of urea. The next topic that will be asked in Viva is glomerular filtration rate, that is GFR. Remember, this is also important for physiology perspective in renal system. Now, this video we are going through a very short summarized version of renal function test. However, in future I will be releasing another video which will have the whole content in much more detail. But as the exams are nearing, we don't have time and we only should focus on the must know areas. So, GFR is actually the volume of blood that is filtered across the glomerulus per unit time. This is actually the single best measure of kidney function. If GFR is alright, we can jolly well say kidney is working fine, right? Both the kidneys are working fine. The amount or the total volume of blood that is generally filtered across the glomerulus per minute is actually 100 to 130 ml. Alright, this is the normal value of GFR. However, we should be very cautious because kidneys can survive or kidneys can continue to function even if it's getting damaged, right? So if you are only measuring GFR, it may not give the big picture or it may not give the clear picture in case of early kidney diseases, when the kidney diseases are setting in. What I mean is patients remain asymptomatic until there has been a significant decline in GFR. Remember, generally we will not test a GFR of random patients. We will only order for renal function test for patients who are suffering from any symptoms, right? Whenever a patient comes to you, then only you will order these tests. However, kidney function test or kidney function has to deteriorate to a very significant level till it becomes symptomatic. So remember, when the patient is already symptomatic, it means GFR has already declined much. So this GFR can be measured very accurately using gold standard technique. So we should know what is the gold standard technique. In fact, we should know at least one of many techniques. There are multiple tiers, okay, multiple stages of measuring GFR, multiple standards. So we should know at least one of them for Viva. The clearance of any substance means the amount of blood, okay, which is cleared of a substance per unit time when it is filtered across the kidneys. You see, in GFR, we are measuring the total volume of liquid or blood that is passing through the kidneys, right? Clearance is the amount of blood that contains a substance, all right? How much blood needs to flow through the kidneys so that that substance will be fully filtered? That is the concept of clearance. So these two, GFR and clearance, are a bit different. So this also assesses the kidney function, but it measures the clearance of some substances by the kidney. So how to determine renal clearance of a substance, right? So you can see it generally will depend whether the substance is filtered or secreted or reabsorbed. Generally, GFR and clearance will vary if these two are different. However, if in some cases GFR equals to clearance and we are only bothered about those. So GFR is equal to clearance when a solute is freely filtered and is neither reabsorbed nor secreted by the kidneys. This is one line you need to remember. Okay? If the substance is reabsorbed or it is secreted, then GFR and clearance rate of that substance will not be the same. It will vary slightly. So, what should be an ideal marker for measuring clearance? What should be the properties of that marker, right? See, these are the properties and you will be asked in your Viva. For example, there is a marker named inulin. Okay? Question often comes, or even in case of creatinine. Explain why type of question will come. Why creatinine or inulin is an ideal marker for measuring clearance? The answer to that question will be these points, these 4 points. So what are the properties of ideal marker? It should be produced normally by the body, synthesized in the body. produced at a constant rate, stable concentration, filtered across the glomerular membrane, removed from body by the kidney, okay, filtered only, not absorbed, not reabsorbed, not synthesized or metabolized. That is, it's inert, relatively inert. All right. Now, remember, creatinine is actually the compound that satisfies all these conditions. However, it is less accurate compared to inulin, right? However, in case of inulin, this first point doesn't hold true because it's a synthetic compound. So, depending on the question, if it's inulin, you measure, omit this point. However, all the rest of the points will hold true. It should be provided at a stable concentration, that is at an infusion. It's filtered across the glomerular membrane and it's inert. It's neither secreted, not reabsorbed, not metabolized, not synthesized, right? So now we come to the viva question, that is, who are the ideal markers for glomerular filtration rate that I was discussing. How you can measure GFR and what is the best marker and what is the best suitable marker, cost effective, like that. So the gold standard, the absolute best is inulin. Remember, by continuous infusion. By continuous infusion, we mean a patient should be injected a cannula, IV cannula, that is a saline bottle, and a constant rate inulin should come from a saline bottle into the bloodstream. So it should be produced at a constant rate. That is the ideal marker characteristic, at a constant rate. We can just artificially produce this constant rate by just making an infusion. Next is the silver standard, which also includes inulin. However, this case we are giving a single bolus injection, a large dose. It's not continually infused, okay? So that also acts as a good marker, but that is not the absolute best like continuous infusion. So inulin and then EDT and DTPA, especially chromium 51 EDT and technetium 99 DTPA. These are complex compounds which also have got the properties of ideal renal function test markers. So ethylene diamine tetraacetic acid and diethylene triamine pentacetic acid. You don't need to know the full forms, just mention these names and you are good. So what about our good old creatinine, right? That is actually bronze standard. Okay, both creatinine and cystatin C are bronze standard because they are not as exactly accurate as compared to these, all right? And these are not made by the body, these must be injected. Since creatinine and both cystatin C are synthesized by the body, there are some amount of hampering or some amount of alteration in the, maybe it may be in micro amount, okay, but still maybe it's synthesized, maybe it's metabolized, not to an extent that might alter renal function, but still if we compare to these are absolutely inert, all right? So creatinine and cystatin C, they are filtered but a bit is secreted, so we cannot rely fully on creatinine compared to these. However, if these are not available, then creatinine is absolutely the way to go. Next, few questions will be asked on what are the conditions that increase or decrease serum urea concentration and what are the conditions that increase or decrease serum creatinine concentration. Remember, uric acid can also be asked, but we don't usually consider uric acid as important compared to urea and creatinine. So you can remember either any one or two of these conditions, okay? So volume depletion means any condition where there is dehydration in the body, serum urea concentration will rise. A diet that is increased in protein will also lead to high urea concentration. And apart from that, tetracycline and corticosteroid group of medicines, blood in GIT and low kidney perfusion due to any vascular diseases, that will lead to increase in serum urea concentration. However, this is important. When urea will decrease, if there is a volume expansion, if there is excess fluid in the blood, then serum urea will decrease. That can be physiological. However, liver disease and malnutrition are very important disease condition where urea will be low. Okay, it's rare, but it happens. So we are concerned about the serum urea to creatinine ratio. Ideally, it should be 20 is to 1. Okay. If it is less than 20 is to 1, we call it post-renal failure, and if it is more than 20 is to 1, we call it pre-renal failure. You don't need to know all that just before the exam. Okay, just remember conditions where urea concentration is increased or decreased, and conditions where creatinine concentration is increased or decreased. So creatinine concentration generally is independent of any dehydration or any dietary modification, right? It only depends on the muscle mass. So male, right? Excess meat in diet, very important. If you just eat 1 or 2 pieces of chicken, I'm just giving you an example, urea value will increase considerably in dietary protein intake. However, creatinine value will not increase that much. Okay, still, if you want to strictly monitor creatinine, or the patient who has got raised creatinine due to hampered kidney function, we often ask him to avoid red meat in diet, right? So muscular body type, the bodybuilder will have more creatine excretion in blood, and other medication like cimetidine. Okay, this is actually an anti H2 blocker. Okay, ranitidine, famotidine, you already know, Rantac. Cimetidine and some other medication leads to increase in creatinine concentration. Now, when creatinine can decrease, it will be low in when the age is low. Okay, children and pediatric population have got actually low values of creatinine. Female, since they have got generally they have got less muscle mass, they will have low creatinine. And diseases that like malnutrition, muscle wasting, okay, prolonged fasting, that will lead to muscle wasting, or any diseases like cancer and amputation. In amputation, the muscle mass of the body is actually reduced. Those will also lead to decrease in creatinine. But remember, female and less muscle mass, low age, that should be your answer when you are asked when creatinine concentration can decrease. Now, if we want to measure the creatinine clearance, the formula is the amount of creatinine in urine divided by the amount of creatinine in serum or plasma multiplied by the volume of urine. Okay, there's a very easy way to remember. So the volume of creatinine in urine, multiplied by the volume of urine, okay, divided by the amount of kidney in plasma. Okay, this is amount and this is in volume. So this is in milligram, this is in milligram, this is the amount of creatinine, and this is the total volume of urine. So UV by P, UV by P, this is the formula of clearance of a substance. In this case, we are discussing creatinine. However, there are few limitations of creatinine clearance, as I told you, because creatinine is secreted by the plasma. So, what should be the ideal marker for renal function test or to measure GFR? That is inulin or EDTA or DTPA, right? Remember, you may be asked in Viva, what is the creatinine clearance? The formula is amount of creatinine in urine, or the concentration of urine creatinine divided by the concentration of serum creatinine multiplied by the total volume of urine. Okay. Next, we need to know a bit about cystatin C. Cystatin C is also a protein that is produced by the body. Its molecular weight is 13 kilodalton. Okay, it's produced by the cells at a constant rate. Generally, it's reabsorbed and catabolized by the kidney and does not appear in urine. Okay, it gets secreted and it gets reabsorbed, right? However, it is freely filtered. If we consider the glomerular membrane, the amount of cystatin C that is present over here, X amount, will get fully filtered through this. However, when it goes to the distal convoluted tubule and loop of Henle, it will be reabsorbed. Okay, but since it's freely filtered across the glomerular membrane, it's a good indicator to measure the renal function tests. Now, generally, for measuring the GFR, we need hours, right? We need to rest the patient, we need to measure the total volume of urine in 24 hours, we need to measure the concentration of creatinine in blood and urine. So it's not an easy procedure, it's a cumbersome procedure. So nowadays we test what is known as estimated GFR or eGFR. Why do we need such a thing? Because this eGFR can actually estimate more or less correctly the total amount of glomerular filtration rate just by looking at the serum creatinine. Okay, there are some other parameters, but mostly we use serum creatinine. So why do we need it fast? Because nowadays there are increased number of patients that require renal transplantation. Okay, kidneys are at risk because diabetes, hypertension, these are rising, right? And we need this information fast because patients require dialysis and transplant, and the less number of transplantable kidneys are in supply. Okay, so there is a constant scarcity, right? There's a constant shortage. So there are two formulas by which we can measure the eGFR. Okay, they are Cockcroft-Gault formula, right? So it states what parameters does this formula use? It uses the formula 140 minus age in years. So we need the age of the patient multiplied by weight in kilogram, weight of the patient. If the patient is female, we need to multiply by a factor of 0.85. Okay, this divided by 72. Okay, in the denominator, these are in the numerator. What is in the denominator? 72 multiplied by concentration of creatinine in plasma. So plasma creatinine in mg per dl. So 140 minus age multiplied by weight divided by 72 into creatinine concentration. So we are only using age, sex, weight and creatinine. We are not looking at the volume of urine, and which will save us much time, right? However, this formula is not used much, okay, because sometimes the value of eGFR may be overestimated, right? So, and why a factor of 0.85 is used in female? Because we assume females have 15% less muscle mass compared to males. However, the most important formula that is used is MDRD equation, right? The MDRD equation, it's a bit complex, okay? It states that, but it's much more accurate. It states that, or the equation, the formula is 186, okay, multiplied by serum creatinine divided by 88.4 minus 1.154 multiplied by age, okay, minus 0.023 into 0.742. This is the factor of female. Do we need to remember all this? No, you don't need to remember all these formula. You just need to know the names. Cockcroft and Gault equation and MDRD equation. Why? Okay, I'm telling you why. Now you can see there's a caveat in this. What's the caveat? Normally, if me or you, assuming we have normal function test, we can do a GFR test and our GFR will be 100 to 130, right? However, eGFR cannot predict our values who have normal kidney function test. So it can only be used accurately if the patient has already got renal disease, chronic renal disease. And also it cannot be used on naturally healthy individuals and children and obese people. This formula will not hold if the age is low or the body mass index is very high, right? So why I'm telling you don't need to remember? Of course, we need to calculate, but there are multiple MDRD calculator that is already available online. So let's look into it. So these calculators are online. You just need to go to the search engine, any search engine. I have opened Google and you need to type MDRD calculator. Then multiple websites will open and all of them use the same formula. So you can either look into MDCalc or QXMD or nephron.org. So both will be same, okay, everything will be the same. So for example, I am now opening the QXMD website, and what are the formula or what are the parameters they are using? First, you need to enter whether the patient is male or female, okay, so the sex is important. Next is race, very important. African American people, Negroes, they have got a huge muscle mass. So the whole thing has been divided for Negroes or not for Negroes, okay. So For African American people, I should not use the word Negroes, it might offend anyone, but just for understanding of Indian population, they understand it better. So African American people, we are not African American, okay, so we will select this. Next we need to give the age in years, right? So age in years is 32, right? Next, we need to give the creatinine. Depending on what unit your lab is detecting the creatinine, it should be in mg per dl or it should be in micromole per liter. Generally, for all standard practices, it is in mg per dl. So my creatinine is 1.1. Okay, so all the four things are complete. So my estimated GFR is 82.45 ml per minute per 1.73 meter squared. This is the unit of GFR. All right, milliliter per minute per body surface area. Right. Now let us look at the values, or what is the meaning of these values. You see, when a kidney is normal, okay, remember it's kidney damage with normal or raised GFR, right? Then it will be more than 90. Since I am having normal kidneys, I already told you we cannot predict on my renal function depending on this MDRT calculator. I need to already have some kidney damage in order for this equation to predict my renal function status. But we know my creatinine is normal, I am not having any symptom, so I am fine. Mild kidney damage or kidney damage with mild GFR, it should be 60 to 89, right? Moderately decreased GFR is 30 to 59. Severely decreased GFR is 15 to 29. And when we need kidney transplantation or dialysis, right, it should be less than 15. So this is the critical or stage 4 chronic kidney disease or kidney failure where we will need kidney transplantation, and this is the critical area where eGFR helps us a lot. So this is it. This is all you need to know in short about renal function test. Remember, apart from this, you might be asked the value of uric acid because it's also a parameter for RFT that is often used by physicians. The uric acid value is slightly higher in males. It is around 3.4 to 7 mg per dl, and in case of females, it is 2.4 to 6 mg per dl. So blood urea, uric acid, creatinine, GFR, the modes of measuring GFR, and eGFR, that is the MDRD calculator. MDRD calculator is using age, race, and the kidney function, that is the creatinine value, right? So, and there is an online calculator. However, the eGFR cannot be measured for healthy individual, children, or obese people. So this is all, and I will see you very soon with another function test video, and we will also be going through revision classes of carbohydrate, lipid, protein, and nucleotide metabolism very soon. So stay tuned. We will see you in next video. Till then, bye and take care.